A 27-year-old woman comes to the physician for a routine examination. She recently immigrated to the US from Haiti. She feels well and is asymptomatic. She has a 6-year history of type 2 diabetes mellitus temperature with metformin was begun 3 weeks ago. She received all recommended vaccines during childhood, including BCG vaccine 20 years ago. A pulse 74, respiration 22, blood pressure 104. Remainder of the examination normal. His finger stick blood glucose is 168. PPD skin test 12 millimeter in duration at 48 hours. An X-ray of the chest showed no abnormal. Which of the following is the most appropriate next step in the management? Okay, ready?
Okay. So the answer is C. Begin isoniazid therapy. This patient should begin isoniazid therapy for treatment of potential TB infection. Controlling the spread of TB relies on the diagnosis and management. This is so small. Okay, I guess that's just how it is. Relies on diagnosis and management of patients with active TB and potential latent infection, which has a risk for reactivating into symptomatic transmissible disease. There is no definitive test for latent TB infection, and diagnosis is based on clinical risk factors and demonstrate immune response to TB antigen. The immune response may be disclosed using the PPD skin test or an interferon gamma release assay. In this patient, receipt of BCG vaccine in Jaho can make interpretation of PPD skin test challenging, as the immune response may be caused by the presence of latent TB or because of prior BCG vaccine. Given this, the CDC recommends interpreting PPD test, skin test the same for BCG vaccinated and non BCG vaccinated individuals. For patients with greater than 10 duration on PPD skin test or positive serum interferon gamma release assay and negative X-ray, treatment for latent TB infection should be initiated if they fall into one of the following high risk group: recent immigration from a high prevalence country, IV substance use, resident or employee of a setting in which people are in close contact, a correctional facility, nursing care home, a shelter, hospital, presence of significant medical comorbidity, or pediatric patients exposed to high risk adult. This favors a shorter 3 to 4 months rifamycin based and isoniazid combination regimen over isoniazid monotherapy, though of the options presented, only isoniazid therapy presents a correct choice. Rifamycin based regimen are preferred given their efficacy, favorable treatment, a relative low hepatotoxic rate.
Isoniazid monotherapy for 6 to 9 months, isn't it? And the rifamycin-based therapy usually preferred for latent tuberculosis infection. And rifampicin daily for 4 months or rifampin plus isoniazid daily for 3 months and rifampicin plus isoniazid weekly for 3 months. Okay.
Okay, next.
Okay, next. A previously healthy a previously healthy 7-year-old boy is brought to the 7-year-old boy is brought to the physician by his father because of 1 day history of right hip pain and acid limb. 5 days ago he fell off his bed while wrestling with a 5-year-old brother. 3 weeks 3 weeks ago she 3 weeks ago he had a cold that resolved within 5 days. He takes no medication. Immunizations are up to date. He is 50 percentile for height and weight. His temperature is 37.6, pulse 100 per minute, respiration 18 per minute, blood pressure 98/66. He is alert and is no distress. Examination of the hips and knees. Shows no swelling, warm erythema, passive motion of the right hip produce moderate pain. Lab studies show leukocyte count 10,000, segmented neutrophil 52%, bands 3%, eosinophil 3%, lymphocyte 37%, monocyte 5%, ESA 20, C-reactive protein 3000. X-ray of the right hip show no abnormality. Ultrasonography hip show mild joint if needle, clear fluid, no organism, long-term complication. Okay. Is it transient synovitis? Are you
I
there?
don't know. I think so.
Okay. Okay.
Yeah, can you hear me?
Yes, yes, I can hear you.
Hello?
Yes, I can
Yeah,
hear you.
okay, okay. I say I think so.
Okay, okay.
Okay. Okay, there are no long-term complications. Most likely diagnosis, otherwise healthy patient with transient synovitis of hip, transient synovitis inflammatory condition involving the synovial lining of the weight-bearing joints, with the hip being the most affected, is not associated with long-term complications. Transient synovitis classically present in children recovering from viral infection. Symptoms include pain on weight-bearing joints, antalgic gain, refusal to abulate tenderness over the joint, and pain elicited with motion. Vital signs normal as a result of lab studies, except for increased inflammatory markers such as ESR and CRP. Antecedent viral infection have been reported. Blah, blah. Diagnosis involves the exclusion of emergent and urgent conditions such as cellulitis, septic arthritis, osteomyelitis, fracture. Treatment supported and involves rest and NSAID. If there is diagnostic uncertainty, arthrocentesis to exclude septic arthritis, along with imaging to assess osteomyelitis or fracture should be done. This patient does not have symptoms of acute infection with an increased ESR CPR. Aspiration of gram stain findings are within normal limits. In addition, this patient recently recovered from a viral illness, making transient synovitis more likely. Next.
Okay. Next. Oh, sorry.
Uh huh.
Okay, one question I want to ask you.
So,
A 37-year-old primary gravid woman at 12 weeks of gestation comes to the physician because of one day history of urinary frequency and moderate pain and burning with urination. She has not had fever and abdominal or flank pain or abnormal vaginal discharge. During the past year, she has had 5 urinary tract infections that begin within 3 days of having sexual intercourse. Each episode resolved after a day of treatment with ciprofloxacin or trimethoprim sulfamethoxazole. She has no history of serious illness. She is sexually active with one male partner. Vital signs are within normal limits. Physical examination include pelvic examination shows no abnormality. Urine analysis shows numerous WBC and bacteria. The patient is prescribed 7-day course of nitrofurantoin. Which of the following is the next step in the remainder? Okay, ready?
mhm, it is. There are. Oh, never mind. Postcoital nitrofurantoin therapy. UTIs classically present in women with dysuria, urinary frequency urgency, supraclavian discomfort. They are often caused by E. coli and gram-negative enteriflora. If untreated, bacteria can travel up to the ureter to infect the kidney, resulting in pyelonephritis. Urinalysis typically shows leukocyte nitrates along with white blood cells and microscopy. Treatment includes antibiotics, common pathogen. UTI are common in women due to shorter urethra and favorable regional environment for bacterial growth. In addition, sexual intercourse can introduce bacteria into the urethra. Wait, how? Okay, wait. Okay. Leading to recurrent UTIs. Because these patients' UTIs are reliably rare, triggered by sexual intercourse, prescribing an antibiotic to take following sexual intercourse is appropriate. Nitrofurantoin is a common antibiotic that treats cystitis and is safe for the use during pregnancy. Next.
Yes, an otherwise healthy 12-year-old An otherwise healthy 12-year-old boy is brought to the emergency department 4 hours after sudden onset severe pain in his right testis. There is no history of recent or vital signs are within normal limits. On examination, the right testis is palpated in the upper hemiscrotum. It is exquisitely tender and twice the size of the left testis, which is normal. The remainder of the examination showed no abnormality. Results of the complete blood count are within reference unless in addition to administration of the morphine, which of the following is the next step? Ready?
Yes. Emergency orchiopexy. Testicular torsion caused by rotation of the testes around the spermatic cord, compression of the blood vessel supply leads to edema, ischemia, and subsequent necrosis. Classically presents with acute testicular pain, tenderness to palpation, scrotal swelling, and diminish or absent cremasteric reflex. The patient may also develop nausea, vomiting, and a lower abdominal pain prior to the onset of scrotal pain. Physical examination may show thyroid intestinal, although that is where if the diagnosis is unclear. Ultrasound will show diminished or absent bowel to the testis. Testicular torsion is an emergency and requires surgery. Surgery will allow for the torsion of the testis and orchiopexis, which is like testicular fixation of both testes to prevent recurrent torsion. That's the most appropriate management. Next,
Yes.
this one doesn't look that bad now. This NBME.
We have done only 4 questions.
I know.
Good job into conclusion.
You could at least like motivate me. I know it's only four, but I mean, it's, you are funny. Like we've done only one question.
A 50, a 56-year-old woman with recurrent ovarian cancer is admitted to the hospital for management of inoperable small bowel obstruction despite undergoing 4 courses of chemotherapy during the past 5 years. The cancer continues to progress. She currently takes no medication. NGT was placed. Her temperature is 37 pulse, 80 per minute, respiration 12 per minute. Okay, blood pressure is 120 by 70. Abdominal examination show distension and decreased bowel sound. Which of the following is the most appropriate next step in the management? Ready?
Okay. Of family meeting too. You see, now you said something. Now I'm starting to get questions from
I am right.
you. Family
Because
meeting.
after reading this question, I thought uh, lots of time that it may not be that easy because there is a twist. That's why I choose this.
His family meeting to determine goals of care. Patients near the end of life, medical
Even if
complications.
the bowel, there is decreased bowel sound, looks like obstruction, isn't it?
Yeah, yeah. That's what I thought we should
Yes,
just use the IT.
the answer is crazy. Okay.
Yeah. As patients near the end of their life, medical complications commonly accumulate that decrease the patient's quality of life, like small bowel obstruction, invasive and whatever intervention. In this situation, it becomes pertinent to weigh the benefits and drawbacks of further intervention to prolong life. Family meetings to determine goals of care can help clarify the patient's wishes. Many patients opt to forego invasive interventions that prolong life but decrease quality of life and may elect hospice care. If a patient is incapacitated, then close family, durable power of attorney, and advance directives should be consulted with regard to the decision to pursue hospice care. Hospice care is a model of healthcare that prioritizes quality of life over prolongation of life, emphasizing the patient badly procedure are incompatible with the hospice care model. Based on models of healthcare reimbursement in the US, patients eligible for hospice care typically possess a terminal illness from which they are expected to die within 6 months. It's not. Did she discharge or now? I was with the what is the ileostomy, IV, parenteral nutrition, and placement of gastrotomy tube are invasive procedures. First, the physician should facilitate discussion with the patient and her family to clarify her wishes for ongoing care. Further, her small bowel restriction has been deemed inoperable, so ileostomy will be inappropriate. Yeah.
Okay. Next. A 30-year-old primary gravid, 11 weeks of gestation comes to the emergency department because of 3-day history of severe, increasingly severe midline to right lower quadrant abdominal pain, increasing vaginal spotting. She has had pain with sexual intercourse during this time. She has no history of serious illness. Her only medication is prenatal vitamin. Waiting to be examined, she has the while waiting to be examined, she has the onset of dizziness. Her temperature is 36.7, pulse 110 per minute, respiration 16 per minute, blood pressure 90 by 50. Uterus is consistent in size with 10 weeks of gestation and tendon to palpation. Till test is positive. Transvaginal ultrasound shows an intrauterine gestational sac to the right of midline and extending into the myometry. There is free fluid in the cul-de-sac, no adnexal masses. Which of the following is the most likely diagnosis?
Ready?
Ready.
So it's corner of pregnancy, damn it. This patient has an ectopic pregnancy in the fundus of the uterus. Fundus. Okay. Near where her fallopian tube meets with the uterine body. Oh, that's the cornea. That's not the ampulla. Never mind. This is referred to as corneal or interstitial pregnancy. Ectopic pregnancy is an abnormal pregnancy in which the fertilized ovum implies in the fallopian tube or the myometrium or the ovary within the peritoneal cavity in a non-endometrial location. Ectopic pregnancy classically presents with vaginal bleeding and pelvic pain. Beta HCG do not increase as expected in ectopic pregnancy, often lagging the normal expected doubling. Ultrasound can be used to confirm a viable intrauterine pregnancy and may be able to visualize ectopic pregnancy depending on its location. Ectopic pregnancy is not viable. Ectopic pregnancy can be managed medically using methotrexate for small early pregnancy, but may require salpingectomy or evacuation with a laparoscopy for large pregnancies. In case of medical treatment failure or in any case of yeah, complications of ectopic pregnancy include rupture, bleeding, and hemoperitoneum. The three cases can result in hemorrhagic shock, which may begin to develop in this patient given her evidence of hemodynamic stability, tachycardia, hypotension, and dizziness, and free fluid. The next best step in treatment of this patient will be emergency evacuation of the pregnancy. Ampullary pregnancy is an ectopic pregnancy that occurs in the ampulla of the fallopian tube, ampulla, which is the most common location of ectopic pregnancy. It similarly will present with abdominopelvic and vaginal bleeding and can cause rupture with the associated hemodynamic instability. However, this patient's gestational sac is located right of the midline and stays in the myometrium rather than being in the ampulla. Thus, corner pregnancy is most likely than ampulla pregnancy. Let me see what is the cornea and what is the cornea versus ampulla. Ampulla.
This is tubal, and in here this is conval or interstitial. This
Yeah,
one,
cornea. Okay, I'm confused. I thought this was ampulla and this was cornea. Okay,
the description. Look at the description. In the
which one?
description, they have said that gestational sac right to the midline. If you put a midline in here, midline is cervical. Then midline right to the midline is cornwall or interstitial, extending to the myometrium. Isn't it? Yes.
Yeah, so cornea is like this entrance.
Yes, right
Isthmus
to the
is
midline. Yes, this one is tubal, which is more common.
isthmus contuber. Yeah, and this one is the ampulla is the big thingy with the. Right, okay, got it. Okay, next.
A3402, a 3.4 kg male newborn has had respiratory distress immediately after delivery. He was born at term and uncomplicated pregnancy. He was born at term following an uncomplicated pregnancy and delivery. He is gasping for air. Trachea is deviated to the right. Breath sound are markedly decreased over the right hemithorax compared with the breath sound are markedly decreased over the left hemithorax compared to the right hemithorax. Breath sounds are shifted to the right. The abdomen is markedly scaphoid. The patient is greatest risk of death for which of the following? Ready?
Yes. It is pulmonary hypoplasia. This newborn presents with likely congenital diaphragmatic hernia, which places the newborn at risk for pulmonary hypoplasia. Herniation of abdominal organs into the thorax compresses the lungs while they are developing in utero. Pulmonary hypoplasia is the result of a complex mechanism that involves direct compression of abdominal organs on the developing lungs. This affects bronchial and vascular architecture with reduced branching and blood supply and increased thickness of alveolar septa. Newborns with pulmonary hypertension commonly develop persistent pulmonary hypertension due to increased pulmonary vascular resistance, resulting in potentially severe heart failure. This collection of respiratory and circulatory difficulties may be rapidly life-threatening to newborn. Treatment involves surgery of the hernia, although management of congenital hernia must also consider the multitude of secondary pulmonary and cardiovascular problems that result from the herniation of abdominal viscera into the developing thorax. Next.
A 68-year-old woman comes to the physician comes to the office because of 4-day history of progressive shortness of breath. She has a sick of PD, type 2 diabetes, mellitus, hypertension, hyperlipidemia, osteoarthritis. Medications are metformin, lovastatin, acetaminophen. She also uses continuous home oxygen therapy. Heart temperature 37, pulse 70, respiration 76, blood pressure 100 by 84, pulse oximeter on the room near oxygen saturation 82%. Diffuse crackles are heard bilaterally. There is S3 gallop. There is 4 plus beating edema of the lower abdomen. Each of the following most likely confirm the diagnosis. Ready?
Mm, sure. It is echo. This patient with dyspnea, hypoxia, diffuse crackles, edema has presentations suggestive of decompensated heart failure. Patients with heart failure are categorized by having either reduced ejection fraction, like systolic heart failure, or preserved ejection fraction, diastolic heart failure. Common causes of heart failure include ischemic heart disease, chronic hypertension, cardiomyopathy, steatotoxicosis, substance use, pulmonary disease. Patients with left-sided heart failure eventually develop backup blood flow into the pulmonary vasculature. That leads to pulmonary edema. These patients may present with cough, dyspnea, apnea, and crackles. May be heard on lung exam. Patients with right-sided heart failure most commonly occur in secondary to left-sided heart failure may present with increased jugular venous pressures, jugular venous distension, peripheral edema, hepatic congestion. On physical exam, patients may have bilateral crackles and the presence of S3, S4 heart sounds. Heart failure is diagnosed with echo. Next.
A 15-year-old boy is brought to the physician because of 3-day history of fever, sore throat, fatigue. He has hemophilia and requires recombinant factor 8 therapy as needed. His temperature is 38.2, pulse 90 per minute, respiration 24 per minute. Blood pressure 100 by 70, blood pressure 100 by 70. Examination show exudative tonsil of laryngitis and bilateral lymphadenopathy. There is tenderness to palpation of the right upper quadrant of the abdomen. The liver is well protein. The splenic tip is palpated on the left dorsal margin. Which of the following is the most appropriate next step in the management?
What does he have? Ultrasound of the liver, CT scan of measurement of serum ASTLT. That's hemophilia. Okay, so is it like a liver? Okay, okay, okay. Maybe. Ready?
Yes.
Measurement of serum AST in ALT activity. Infectious mononucleosis. How did they come up with infection in this? It's a viral illness caused by EBV virus. EBV virus transmitted through respiratory secretions and saliva, commonly acquired by teenagers in young adults. While B lymphocytes are the cell type infected, atypical lymphocytes seen on peripheral blood are acute, actually cytotoxic. CD8 T lymphocytes actually cytotoxic. Okay, wait. While the B lymphocytes are the cell infected, a typical lymphocyte seen on peripheral blood are actually cytotoxic CD8 T lymphocytes that are reacting to the viral infection. As a result, patients often have leukocytosis with lymphocytic predominance. Cytomegalovirus is another cause of infection mononucleosis, and an acute HIV infection may present with similar symptoms. Clinically, the syndrome is characterized by fever, lymphadenopathy, typically involving the posterior lymph nodes, and hepatosplenomegaly along with pharyngitis. Okay. Patients with infection mononucleosis will typically test positive for monospot test which detects heterophile antibodies through the agglutination of sheep and host erythrocytes. Patients with mononucleosis may present with cholestatic hepatitis. Liver function testing typically shows mildly increased serum concentration of transaminases, alphos, and bilirubin. Severely increased transaminase concentration should prompt evaluation of other possible causes, such as cytomegalovirus or viral hepatitis. Liver function testing is not necessary for all patients with infectious mononucleosis, but may be desirable in particular circumstances, such as patients with underlying hepatic disease or coagulopathies, in whom an assessment of hepatic status is particularly important. Treatment is supportive, and patients should be counseled to avoid any contact sports until splenomegaly has resolved
Okay.
because of the risk of splenitis. Ultrastimulation of hepatosplenomegaly in the setting of infectious mononucleosis, ultrasound may provide an increased ability to detect enlargement of the liver or spleen. Okay, in cases where the physical exam is equivocal, in this case, hepatosplenomegaly has been already identified on clinical exam. Okay, got it. Next.
A 12-month-old girl is brought to the physician 6 hours after arachidontia, swelling of the lips and itchy rash over her face and she's drooling and has vomited twice during this period. Her mother says that her daughter had a similar rash once before, but it is resolved within it is resolved within an hour. The girl is breastfed and eats some table foods. Prior to her symptoms today, she ate ice cream for the first time. She appears alert and active. Examination shows multiple erythematous macular lesion over the face, neck, hands, wrist, bilateral and expiratory wheezing is heard on auscultation. Which of the following is most likely? Okay. What is your diagnosis?
Yeah, some kind of allergy. Oh no,
Is
like
it?
like like dairy allergy, like to milk and all these things. Like to oh no, it doesn't make sense.
She's drooling and vomited twice during this period.
Oh, that's where you're trying to go. Okay. So you want to do lateral X-ray of the neck?
Maybe you were right.
No, maybe you're right.
You were on the right track. Don't change.
Okay, okay. Radiology that okay. What did you think it was? Like the hemophilus one?
Sorry,
What did you think it was? What did you
I
think?
thought it is like epiglottitis or like croup.
Epiglottitis.
Croup. I am thinking about croup
Oh, I thought you wanted epiglottitis. I thought
or
that's okay.
epiglottitis also comes with the lateral neck X-ray, isn't it?
Yeah, yeah, that's what I'd say. Maybe lateral naked, but epiglottitis. What does it have to do with table food and the ice cream?
Yes, epiglottitis comes with or a croup comes with barking type of cough, but there is
Yeah,
no such barking.
yeah, and epiglottitis will be like non-immunized and non-immunization and all that. Okay. Okay, anaphylaxis, severe type 1. Okay, she has anaphylaxis. Okay. Type 1 sensitivity reaction presents following exposure to allergen. Most common medications, food, insect stings, mediated by activation of IgE, which leads to release of histamine and cytokines from mast cells and basophils. This subsequently leads to acute inflammation and profound vasodilation of multiple organ systems, generally cardiovascular, respiratory, GIT, and skin. Symptoms include the rapid onset of bronchospasm with dyspnea and wheezing, urticaria, flushing, nausea, emesis, edematous lips and tongue, hypotension, tachycardia. When severe and untreated, it can progress to circulatory collapse with cardiovascular arrest or death due to asphyxiation and airway obstruction. Treatment includes administration of epinephrine, antihistamine, bronchodilators, steroids, as well as IV fluid. Severe cases may require endotracheal intubation and administration of vasopressor. Epinephrine is a vasoconstrictor, should be administered first as it decreases airway edema and hypotension. Milk protein allergy, which occur in both breastfed and formula-fed infants, is a likely cause. However, the ice cream may have contained traces of another allergen. Radioallergic, whatever, testing used to identify antibodies against particular antigens can be used to identify specific trigger or triggers. You want me to read the other ones?
No.
The okay, next.
A 37-year-old man comes to the physician because of the history of fever, progressive fatigue, abdominal pain, nausea, vomiting. Oh, he also has dark urine, clay-colored stool. During this time, 6 weeks ago, he traveled to Central America, where he ate the local food, including raw shellfish and vegetables. His temperature is 38, pulse is 90 per minute, regular respiration are 20 per minute, blood pressure is 110 by 85. Examination shows scleral icterus. The liver is tender and palpated. Liver is tender and palpated 6 centimeter below the right costal margin. Hemoglobin 15, MCB 100, bilirubin 7.1, ALP 105, AST 2000, ALT 1500. Without treatment, which of the following is the most likely outcome of this condition? Ready?
One moment. I know it's Hep A, but is Hep A
Hep
one of
A
the
is completely resolution.
okay, Hep A is good. Okay, got it. Which ones are the ones that can cause carcinoma? The Hep
Hep,
C and Hep B only.
Hep C is chronic. Hepatitis B can cause carcinoma.
Hep
Hep
C
C
is
is chronic, can cause
chronic.
hepatocellular carcinoma, but B has the propensity of having carcinoma. B has,
Okay.
yes.
Complete resolution. This patient presenting findings of nausea, vomiting, abdominal pain, icterus, hepatomegaly, right upper quadrant, 6 weeks after traveling to Central America. And wait, what is Central America? Is it the Latino places or is it the? I know North
You are
America is the.
asking me
I'm so, never mind. I know North America is the US,
if it is
but
related to like
I'm just okay. Never mind. I'm thinking
Trump,
it's the
then I know that.
okay, probably the Latino places. Okay. And eating raw shellfish is consistent with acute Hep A. Hep A is non-enveloped single-stranded RNA virus that spread through fecal oral transmission. It's commonly acquired through ingestion of fully cooked, improperly handled or raw foods, including shellfish. Hep A has incubation period of several weeks, presenting signs and symptoms: fever, nausea, vomiting, poor appetite, abdominal pain, jaundice, hepatomegaly. Although many patients are asymptomatic, lab includes transaminitis, increased outfalls, hyperbilirubinemia. The diagnosis is confirmed by serologic test detection of anti-Hep A IgM antibodies. Hep A infection is typically self-limited illness and does not progress to chronic infection. Okay. Okay, it says Hep B is more commonly associated with chronic infection leading to cirrhosis and hepatocellular carcinoma. So Hep B, chronic infection in cancer. For this reason, blah blah blah. It doesn't say anything about. Okay, and then injection drugs users, men who have sex with men, and patients with HIV or Hep C. Okay, never mind. Oh wait, fulminant hepatitis is not commonly seen in Hep A. Autoimmune hepatitis, Hep B, and Hep C are more likely to cause fulminant hepatitis. Okay, and then chronic carrier is not associated with Hep A. Generally, once a patient has been infected with Hep A, the disease is self-limiting. Okay, never mind. Okay, next.
A 35-year-old woman with SLE to the emergency department because of 3-day history of sharp mid-chest pain that worsens with inspiration and lying on her back. Her only medication is hydroxychloroquine. She appears mildly uncomfortable. Her temperature is 38.1 degrees Celsius. Pulse 96 per minute. Respiration 14 per minute. Blood pressure 135 by 87. Examination shows mallow rash. The lungs are clear to auscultation on examination. There is scratchy, high pitched sound is heard on the over the lower left sternal border. There is erythema swelling worm of the wrists. ECG is shown. Which of the following is the most initial pharmacotherapy? Okay, ready.
Yes. It is ibuprofen. This patient with lupus now presenting with pleuritic chest pain that is better when leaning forward. An ECG showing diffuse ST elevation, likely pericarditis. Pericarditis classically presents with central chest pain, which is often pleuritic. It's worse when supine and proves when leaning forward. It can occur in patients with inflammatory infections or malignant conditions such as viral infection, lupus, tuberculosis, lymphoma, and can present as a complication of MI. If not treated, pericarditis can lead to development of pericardial effusion, which, if large and quickly accumulating, can result in cardiac tamponade. So pericarditis, pericardial effusion in tamponade. On cardiac exam, pericarditis discloses that diastolic friction rub, described as harsh sound heard on diastole. The condition is diagnosed clinically and supported by increased inflammatory markers. ECG may show ST elevation with PR depression. Treatment anti-inflammatory medications such as NSAIDs, steroids, and colchicine. Okay. Next.
Yes. A 70-year-old man is brought to the a 70-year-old woman is brought to the office by niece because of 6-month history of frequent falls. She says he has fallen backward suddenly while walking approximately once monthly during this time. She adds that he has a tendency to look down at his feet while walking. Recently, his speech has become slurred, and he has he has had several choking episodes while eating. He he also had difficulty breathing. He has not had lightheadedness or standing, difficulty with urination, constipation, changes in mood, or hallucination. Physical examination shows mild nuchal rigidity, symmetric rigidity of all extremity. There is no tremor. There is impaired visual gaze. There is impaired visual gaze that is worse when patient attempts to look down. He has decreased stride length, one gait. impaired balance when turning. He has poor in inoculation. Okay. Okay, which of the following is the most likely diagnosis? Ready?
Yes, can you give me a minute? I have to
Yes,
answer this.
yes, yes,
Yeah.
obviously.
Where was that? Oh, did I share my screen? Yeah, I did. Okay. Is progressive supranuclear palsy. Omar, can you hear me?
Yes, I can hear you.
Okay. Progressive supranuclear palsy, a typical Parkinsonian disorder, is neurodegenerative disease associated with tau positive neurofibrillary tangles in the basal ganglia cortex, brainstem. Patients typically present around age like 65 with gaze instability or oculomotor deficit, like classical vertical gaze palsy, um, frontal lobe deficits, bradykinesia, and muscle rigidity. The gait pattern varies in step length and base width, though patients typically walk and pivot too quickly as a result of impulsivity from frontal lobe damage, leading to backward falls. Definitive diagnosis occurs by neuropathologic exam illustrating a pattern of neurofibrillary tangles in the characteristic distribution. Neuroimaging illustrating midbrain and or cerebral cortex atrophy supports the diagnosis. They typically occurs within like 6 to 9 years after disease onset. Management is supported and includes physical and occupational therapy, along with advanced care planning. I guess it's not Parkinson, is presenting with dysfunction of voluntary movements in the form of bradykinesia, resting tremor, rigidity, postural instability. Some patients with Parkinson's disease exhibit um, pseudobulbar palsy, which is the combination of dysphagia, dysarthria, facial weakness, and emotional liability. This patient also has vertical gaze palsy, which is atypical of Parkinson. Okay, next.
Okay. 35-year-old primary gravid 35-year-old primary gravid is brought to the emergency department by paramedics after a neighbor called emergency services because the patient was being disruptive and combative and wrote to the ED. Finger stick blood glucose concentration was 45. IV 50% dextrose was administered and her mental status improved. On arrival, she is fully oriented. She has 10-year history of type 2 diabetes mellitus. Treated with insulin, she says she is pregnant but does not know what she had her last menstrual period. She has not yet initiated prenatal care. She has smoked 2 packs of cigarettes daily for 23 years. She does not drink alcohol or illicit drugs. Vital signs are within normal limits. On examination, the uterus is non-tender. Fundal height is 2 centimeters below the umbilicus. Fetal heart rate is 146. Pelvic ultrasonography shows a single intrauterine fetus consistent in size with 17 weeks of gestation. The thighs and the legs are fused, and there are two tibial bones within a single soft tissue muscular compartment. And the amniotic fluid index is 2 centimeter. Which of the following is the most likely outcome of this patient's pregnancy? Okay.
Ready?
Yes.
Okay. So stillbirth caudal regression syndrome is a congenital condition characterized by partial or complete absence of the sacrum, and in some cases, the lower lumbar spine. Caudal regression syndrome falls under the umbrella of diabetic embryopathies and includes conditions in which there is anomaly in the embryo associated with diabetes in the mom. Most often, this is caused by poor control of diabetes and hyperglycemia prior to and during pregnancy. The theorized pathophysiology of these disorders include Involve abnormal myonocytal uptake, which leads to abnormalities in the arachnoid and prostaglandin pathway. This abnormality leads to birth defects and often early pregnancy loss. In fetuses with caudal regression syndrome, clinical features and symptoms are dependent on the spinal lesion level as well as the severity of the abnormalities. They commonly include concurrent anorectal malformation, anaplasia of the sacrum. While it's possible for fetus with caudal regression to survive birth and live mostly functional life, to some extent, those with significant abnormalities such as the fetus in this case are not likely to survive gestation. This patient fetus has minimal differentiation of the bilateral lower extremities, as well as amniotic fluid as superlow, which is 20% of the lower and likely incompatible with life. Cerebral palsy is not generally associated with diabetic embryopathy or caudal regression syndrome. While central CNS deficits are common, they stem from neural tube defects. Some examples of neural tube defects in diabetic embryopathy is anencephaly, spina bifida, and myelomeningocele. That word. Next.
Okay. Mm, a 92-year-old woman is brought to the emergency department. A 92-year-old woman is brought to the emergency department uh, because of 1 week history of generalized fatigue and weakness. She has she has been a resident in a skilled nursing care facility for 30 years and is non-ambulatory. This morning she became agitated, and when the medical staff carefully lifted her arms and legs to move her on the bed, she has intestinal malabsorption syndrome, pulmonary fibrosis, dementia, and global deconditioning. She receives chronic parenteral nutrition. She appears pale and is oriented to person, but not to place or time. She can she can follow simple comments. Palpation of the upper extremities and the thighs produces pain. She can flex and extend the elbows and wrists and dorsiflex and plantar flex the ankles, extends to bilateral. Sensation is intact over the extremity skeletal surface, pseudo fracture of the femur and proximal ulna bilateral. Which of the following serum concentration is most likely to be increased in this patient? Ready?
Yes. Is PTH. This patient presents with signs of osteomalacia secondary to vitamin D deficiency. Vitamin D plays a role in serum calcium and phosphate homeostasis by promoting intestinal absorption of calcium and phosphate, increasing bone mineralization at low concentration, and bone resorption at high concentration. Vitamin D can be deficiency can be caused by malabsorption in the intestinal tract, malnutrition and insufficient dietary intake, and decreased sun exposure. Elderly patients are at particular increased risk of vitamin D deficiency as a result of decreased vitamin D synthesis with age, lack of sunlight exposures. Patients dependent on parenteral nutrition often have poor oral intake and are very frequently vitamin D deficient. Decreased concentration of vitamin D result in decreased intestinal calcium absorption and hypocalcemia sensed by the PTH parathyroid gland with calcium sense, leading to an increased in secretion of PTH to normalize calcium levels. Increased PTH stimulates osteoclastic bone resorption and distal DCT, distal convoluted tube calcium reabsorption, and phosphate excretion in the kidney. These mechanisms are often inadequate to maintain calcium homeostasis and lead to osteomalacia, an adult form of vitamin D deficiency characterized by loss of bone mineral density and abnormal osteoid mineralization. Patients with osteomalacia frequently present with non-specific symptoms including muscle weakness, muscle pain, bone pain. In later stages, may have bone deformity, gait alteration, and falls. Patients may also have significant symptoms, signs of where am I? Signs and symptom of hypocalcemia, including confusion, memory difficulties, myalgia, perioral and peripheral paresthesia, pseudofractures known as loser zone, are a type of insufficiency fracture that are characteristic of osteomalacia and are visible on X-ray as line of lucency corresponding to areas of low bone mineral density. Pseudofractures typically occur in the ribs, posterior ulna, pubic and iliac bones, and in the femoral neck or shaft. Treatment is with oral supplementation of both vitamin D and calcium and typically results in improvement of symptoms, weakness, and pain, as well as normalization of lab values. Let me see, those are zones. Yeah. Hmm, okay. Hmm, it looks like okay.
Which one? Okay, this.
It's like the loser zone. It's like this thing. It looks like a I don't even know, like a it's like a fracture, but not really.
So in
Like you see.
osteomalacia, we will find this loser zone, pseudo-fracture. Of
Mm-hmm.
both, is it found
Hmm?
in the rickets also?
Oh, I don't know. You know what? I don't know. Mm-hmm.
Because rickets and osteomalacia has both pathophysiology.
Very good. Yes, they have found this in the rickets too.
Okay,
Okay, next.
a 4-year-old boy is brought to the emergency department by his mother after he refused to walk or bear weight on his left leg in this morning. She says he has been irritable during the past 3 days. He has had he has a 3 month history of episodes. He has a 3 month history of episodes of moderate pain in his shoulders and the ankles, but the pain has not been as severe as his current symptoms. His mother says he bruises easily. He has not had recent trauma or fever. He was born at term by spontaneous vaginal delivery following an uncomplicated pregnancy. He walked at the age of 11 months. He attended preschool. He is at 17 percentile for height, 60 percentile for weight. Vital signs are within normal limits. There is no gingival bleeding and the teeth are intact. There is deep ecchymosis over the anterior aspect of the left thigh. The skin otherwise appears normal. The patient is unable to extend the left knee because of pain. Which of the following is the most? What is your diagnosis?
Isn't it hemophilia or no?
If it is hemophilia, PT should isn't it high?
Wait, hemophilia 8. 8 is part of the intrinsic, so your PTT will be I.
Oh, yes. There
Okay.
is no gingival bleeding and teeth are intact.
Mm-hmm.
Okay, let's see.
Okay. What do you think it was? What do you think it is, though?
Sorry.
What do you think it is?
I am thinking about von Willebrand disease.
Wrong with it, Brand. But one Willie Brown wouldn't they have the bleeding and the gingival bleeding and all that?
You are right.
Okay.
I'm
Factor
thinking
E.
too much.
No, no, no. I thought von Willy Brandt first, but then
Okay,
I was like, oh, they made sure they said no gingival bleeding, no this, no this. Probably it's not that.
okay.
Factor A deficiency, hemophilia A, most likely expand this patient significant bruising and presumed presentation of hematrosis. Hemophilia X links or boys that arises because of genetic deficiency of factor A synthesis. For activity, patients often present with easy bruising, hemorrhage involving muscles and joints. Hemorrhage can be life-threatening, often require transfusion of factor A to replace the. Yeah. Patients can acquire antibodies against exogenous factor A, which can necessitate larger transfusion. As the PTT measures the activity of the intrinsic cascade, whatever, which includes factor A, the deficiency of factor A leads to prolonged PTT. However, the PT is normal as it measures the activity of the extrinsic cascade, which remains intact in patients with hemophilia A. There is no effect on the concentration of or activity of platelets. Next.
37-year-old woman comes to the pregnancy. Sorry, comes to the emergency. Comes to the emergency department 2 hours after cutting her hand while working in the garden. She received a tetanus vaccine 3 months ago. Examination shows a clean wound after the wound is treated. The patient insists on receiving another tetanus shot. The physician explains the previous vaccine adequately protects her. The patient insists that it be repeated. Which of the following is the most appropriate? Okay, ready?
Ready?
Yes.
Refuse to administer another vaccine and repeat the explanation. Routine tetanus toxoid vaccination is recommended for all previously immunized adults every 10 years. Tetanus toxoid should be given following injuries in previous vaccinated patients if the wound is minor and clean. And the most recent vaccination was greater than 10 years. Or if the wound is severe and contaminated and the most recent vaccination was greater than 5 years. In this case, the patient recently received vaccination and presents with a clean minor wound. Repeat administration of tetanus is not indicated in this case. This while tetanus toxoid is generally extremely safe, rare adverse events have been reported like fever, febrile seizure, transient myelitis, polyneurosis, urticaria. And patient requesting non-indicated or necessary medical care is a common ethical challenge that most physicians will face. The physician must balance between ethical principles of autonomy and non-maleficence. Physicians are not obligated to provide medical services that are not indicated, not necessary, or harmful. Additionally, billing for unnecessary services may be taken as fraud. The best approach in this instance is for physicians to try to understand the patient reasoning for wanting vaccination, reiterate that vaccination will not be beneficial and will expose the patient to avoidable risk, and refuse to administer the vaccine. Next.
Yes. Okay. sorry, a 32-year-old uh, a 32-year-old woman is brought to the emergency department because of a 1 hour history of palpitation, tremor, lightheadedness, sweating. She has not had loss of consciousness, chest pain, shortness of breath. He has had similar episodes in the past, which were relieved by eating and rest, and her only medication is lorazepam. Need generalized sensory disorder. There is no family history of similar episode. Temperature is horizon, pulse 120, blood pressure 138 by 90, glucose 95. Which of the following is the most appropriate next step? What is his problem? His magnesium is normal.
Mm-hmm. It's normal.
Is it thyroid? But
No, it's
but
probably
wh-
something with.
which were relieved by eating with rest. Mhm. But think about insulinoma, glucagonoma, this type of thing.
No, really. It's something with the glucose. Glucose is the only abnormal lab. Glucose is low. So his all these signs are signs of hypoglycemia. She has hypoglycemia, and yeah, hypoglycemia is the whatever diagnosis. But how do you diagnose hypoglycemia? I
C-peptide,
think
yes.
you
You are
think so.
yes, yes. Like
Okay.
insulinoma, glucagonoma, insulinoma, this type of diagnosis is done by what can I
Yeah,
say?
that's
By C-peptide. If insulin is high, C-peptide is high, that is insulinoma.
mm, okay. Measurement of C-peptide and glucose concentration are obtained when there are concerns for insulinoma. C-peptide. Okay, insulinomas are rare tumors of the pancreatic islet cells that inappropriately produce excess amount of insulin and C-peptide, resulting in hypoglycemia. Signs and symptoms of insulinoma include confusion, difficulty concentrating, sweating, fatigue, weakness, fainting as a result of hypoglycemia. Symptoms are often precipitated either by a period of fasting or strenuous exercise. Acute management of hypoglycemia is paramount for these patients to avoid more serious complications. Insulinomas are generally small and benign, but have been found on occasion to grow larger and metastasize. Diagnosis can be made by measuring 72-hour fasting serum insulin and glucose concentration, C-peptide concentration, as well as CT scan and MRI ultrasound to locate and characterize the tumor. Definitive treatment of surgical is surgical removal to deoxycyte.
Diazoxide.
Dioxide can be used to decrease insulin production in the interim. It's not, I was confused between that one. Measurement of cortisol concentration is obtained when there is concern for adrenal insufficiency, like Addison, Cushing disease, or Cushing syndrome. Cushing disease and Cushing syndrome presents with hyperglycemia, not hypoglycemia. Okay. Addison can present with hypoglycemia, but characteristically will also present with hyperpigmentation of the skin, weight loss, decreased appetite, low blood pressure. Okay, she has normal blood pressure. Okay. Next.
What is your diagnosis?
What? I don't know. I can tell
Think.
you that from here. I don't know. Is it a woman? If it's a woman, maybe multiple sclerosis. I don't know.
Yes, you are right.
Oh,
It is multiple sclerosis.
okay. Okay.
So I'll read the last line. Which of
Okay.
the most appropriate pharmacotherapy to decrease the recurrence of similar symptoms?
Oh,
And now tell
recurrent.
me the diagnosis. So now tell me the treatment.
Oh,
You don't need
no.
to read this thing.
Uh, recurrence. Recurrence. I think steroids is when it just happens.
Yes, and
Uh,
for recurrence,
uh, 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 Glatimer.
yes, that is the answer.
Okay, let's see.
This type of MRI will save your time.
I was still gonna read that. There is no way. I was still gonna read the question. So, I was like, yeah, yeah, I was still gonna read the question. I'm sorry. I just answered because I was like, okay, let me just guess. But I cannot guess on the exam. Like I'm gonna be too no. Mm-mm.
But
Um,
if you waste your time on this type of thing, like if you are unable to answer the last two or three questions, you will be
yes,
so sad.
I'll be. Unless now this is like around the last questions and I'm running out of time. So I'm like, okay, you have to pick something. Just pick something. You have like 20 seconds.
Like
Will
the
be
last 4 or 5 questions, I have found that the last 4 or 5 questions is very
easy.
easy.
Yeah. I'm not, and it's like that. I'm swear. I think it's like that even during the exam. I feel like I noticed that even during the real
Yes,
exam.
and
Yeah.
like it it actually makes us so tempted, and actually these things make us so frustrated that we have done a sin like after seeing the last two, because you have like 1 and 1.5 minute and you have 5 questions to answer. It is not
Yes.
possible.
Yeah. Mm-hmm. So there, that's true. But something I learned: just pick something. Don't leave any question. Yeah. Don't leave. Like I swear, oh my, like I know this is
No,
one
no,
minute.
I answer
Yeah.
like if I get 1 minute and if I have to pick the 40 question, I will try to do that.
Yeah.
That's
Just
my way of like whatever it takes. But
first, I
uh,
didn't I didn't believe it when. But then when I took the exam the second time, I swear
yes,
I know I was gonna, because I only missed I only failed by like 4 points. So I knew if I had, and I missed like 20 something questions that I couldn't get to because I was running out of time. And Divine has said in his, just pick a letter C and just click C in all click C in all the questions. Click C, don't leave any question blank. And I was like, no, 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 no. I'm gonna make sure whatever question I'm able to get to, I need to make sure I have the right answer. But it's impossible because you don't even know if you're getting the right answer. But yeah. So at this point, yeah. If you have 1 minute and 5 questions, just pick whatever, pick a letter, whatever A, and just pick A on everything or C on everything or something. Or if it's a question like this one where you feel like with the image you can, yeah, just go with the image. Don't even read the question. But yeah, it can make you. Of course, you're gonna just barely pass. It's not like you're gonna, barely pass, but at least you're passing and you're done. With this stupid exam. Anyway, I'm having PTSD now.
no, no, uh, don't pressurize yourself. You are in a good shape. Just give the exam and just
That's where,
leave.
like, sometimes I wake up at night and I just yell. Like I dream about the exam and I just wake up and I just yell. I'm like, this is like
No, no.
so.
If these things, uh, you should overcome this thing. Like
Yeah,
you know everything, you know all the things. Just what you need to do is to calm yourself down and
yeah.
just deal all the questions. Inshallah,
Yeah.
you will get a great mark this
Oh,
time. I hope so.
this is just so. Oh my god. Anyway, you know how they say when you pass the step one, it's like, oh, that's it. You're done. This is the most. This is
Don't
this word.
don't look at the people.
Mm,
Those
mm,
who got chance, they actually
mm.
say this type of thing, and those who do not,
Right.
and not all people are lucky. So they are lucky. Uh, they can say so. We are not that lucky. Maybe
Yeah,
in future we may be. So
yeah,
don't
that's
think
really.
about others.
So that's the reason. Because when I passed my step, I was like, "That's it. That's it. I'm a doctor. There is nothing else that can stop me. That's it. I'm a doctor. That's it." And then I knew I was not passing for step two. I knew I was not passing my practice test, but I was like, everybody says step two is easier than step one. I just have to go sit down and take it. Let me not waste my time. Everybody says it's easy. That was because I was following that. That was like everybody says it's easy. Just go sit down. Don't waste time. Go sit down, take it. You're gonna pass. That's it. And look at me. I didn't even pass one practice test, and I went and sat down, and I failed. And I was surprised how I was like, why are you surprised? You didn't even pass one practice test. Why are you surprised that you failed? Of course, you're gonna fail. But yeah, but the second time I was like, I really thought I was prepared because I had passed well, I didn't pass all the practice tests, but I passed like three and I felt like three. So I was like, yeah, I'm more prepared. I feel like, yeah, I'm probably going to barely pass, but I'm going to pass. And that's when I don't know if I freaked out I don't know. I started running out of time in all the blocks, running out of time, running out of time. And I ended up like 20 something questions that I could not answer. So in my mind, I already knew I failed. Like, but people were like, no, sometimes it's the experimental questions. So you may have it's just all experimental questions. Just think like that. I was like, nah, no, you failed anyway. So this time, I'm not running out of time. I'm just gonna pick a letter and just yeah. I'm not leaving any questions blank. Mm-mm. Mm-mm. Nope. Okay. Mm, Let me say sorry about that.
No, no,
The,
no problem.
the patient's presentation with neurologic symptoms in various times and locations, as well as MRI showing T2 hyperintense lesions in the white matter. T2 hyperintense lesion. Okay, this one. Lesion the white suggests diagnosis of MS. MS is an immune-mediated demyelinating disease. Onset usually between 20 to 40 years old and is most common in women. Additional risk factor includes residing in temperate climates and having a family history of MS. Presenting symptoms depend on the location of the lesion. Optic neuritis common manifestation typically presents with poor visual acuity and consequent apparent defect on physical exam. According to McDonald criteria of MS, the patient must have evidence of the malinating lesions that are separated in time and location. This evidence can be based on subjective symptoms and or imaging evidence. This patient presents with episodic neurologic symptoms that could be localized to different CNS location, optic nerves, or whatever, at different times. Oligoconal bands of immunoglobulins indicating immunoactivation can be found on CSF, but are not necessary. Treatment includes steroids for symptomatic management or acute flares and long-term disease-modifying treatments such as interferon, monoclonal antibodies, and immunomodulators. Also, you don't use IV. IV immunoglobulin is a pool immunoglobulin used to treat several autoimmune disorders such as Guillain-Barré. However, one clinical trial in MS found no benefit. Thus, IV immunoglobulin is not used in that. Oh, IV methylprednisolone is used to decrease symptom duration during acute MS flare, especially severe flares that require hospitalization. Plasmapheresis can be used for patients with MS flare refractory to steroids. Okay, that is. Next.
Yes, a previously healthy 1-year-old boy is brought to the emergency department because of difficulty of breathing for 12 hours. Over the past 2 days, he has had a cough, clear nasal discharge. His temperature is 36.5, 99.7 degree Fahrenheit. Pulse is 180 per minute. Respiration 60 per minute. Blood pressure 70 by 46. He appears extremely anxious, apprehensive. Examination shows cool, pale, motile extremities, pulse or thready scattered pieces. Bilateral crackles are heard on auscultation. There is a gallop, no murmur. The liver is tender and palpated 6 centimeters below the right posterior margin. Capillary blood gas analysis, while breathing supplemental oxygen shows PO2 is 7.02, PCO2 28, PO2 80. An X of the chest shows mild cardiomegaly and hilar infiltrate. Which of the following is the most likely diagnosis?
PCO2 is low.
Acidosis. Respiratory acidosis, isn't it?
How is it? Respiratory. PCO2 is low.
Sorry.
Not
Yes, it
really.
is respiratory acidosis.
Why? PCO2 is low. Why is
pH
it?
is low. pH is low. And for metabolic, for respiratory happens, PCO2 should be reverse. PCO2 should be low. Acidosis. No, no,
What?
no, 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 no. So sorry.
Wait, what? Okay.
Acidosis.
So it's probably metabolic acidosis. I don't know. I don't know. It's some kind of acidosis, I guess. Mm, he has this is weird. Shortness of breath, even on
Yeah, even
liver.
temperature is low.
Oh, temperature is low too. Okay. Blood pressure is low, and she has motor, blah 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 blah, and crackles on the lungs, in cardiomegaly.
It's myocarditis.
I think so. Mm,
How? 1 year old.
1 year old. But I mean, he had a cough and whatever, something. No. Or bronchiolitis is what the group or the
No, no,
RSV
bronchiolitis is normal. It usually happens in 2 months to 2 years of life, but in that bronchiolitis, the patient is normal.
patient is normal.
Don't think so. That is bronchiolitis.
So it's pneumonia will have fever.
Myocarditis has there is high possibility of having myocarditis
Myocarditis in a 1 year old.
because there is cardiac problem also.
Or maybe why is not dehydration?
Dehydration cannot give you gallop. Dehydration cannot give you bilateral
Oh, he
crackles.
has a gallop. He has okay, okay. I thought he said there is no gallop. There is
Yes.
a gallop with normal
So gallop rhythm, there is bilateral crackles. Looks like there is problem in the heart.
bilateral crackles.
Bilateral basilar crackles, signs of heart failure.
Axial crackles. Okay, okay. So we think it's myocarditis. Okay, let's go with myocarditis. The answer is myocarditis, Miss White. Infant with recent history of upper respiratory infection. I never seen in like a really baby like that. Infection now presenting with cardiogenic shock has symptoms consistent with heart failure secondary to myocarditis. Patients classically present with evidence of decompensated heart failure, including dyspnea, atopnia, peripheral edema, potentially with evidence of shock, like poor peripheral perfusion, increased lactic acid, which is metabolic acidosis, so it's a metabolic acid. With this patient, recent upper respiratory illness, the cause of heart failure is most likely viral myocarditis. Refers to inflammation of the cardiac myocyte. Notable causes is viral myocarditis include Coxsackie B, Parvo B19, HHV6. What was HHV6? Like
Roseola,
roseola, okay. Adenovirus and HIV. Further diagnostic evaluation with X-ray and echo can support the diagnosis by confirming cardiomegaly, pulmonary interstitial edema, and decreased ejection fraction, indicating abdominal systolic function. Treatment is generally supportive as most cases resolve with time. Some patients may require diuresis and depending on severity, mechanical, pharmacologic, and nootropic support or transplant. Bronchiolitis, respiratory tract infection, RSV. Patients typically present with problem of upper respiratory symptoms followed by dyspnea and wheezing. And though it can cause respiratory distress due to mucus plugging of small airways, it does not cause volume overload. Yeah, what you were saying, pulmonary edema, galloping. Dehydration may lead to hypovolemic shock in children if severe, as with this patient, those with hypovolemic shock may present with the metabolic acidosis, lactic acid. However, they generally show signs of hypovolemia, not hypervolemia. Mm. Examination of patients with dehydration does not generally disclose hepatomegaly and all this bilateral crackles. Okay.
Okay.
You want to take a quick break?
Okay.
Okay. See you soon. Ready? Omar.
Yes.
Oh, ready? Sorry.
Yes. Yes.
Begin surgical exploration in the OR. Beginning surgical exploration in the OR is the most appropriate next step. In this case, the patient presentation is suggestive of necrotizing fasciitis, which may occur following cellulitis, trauma, or invasive procedure. Common causative agents is staph and strep. Clostridium bacteroides. Necrotizing fasciitis is characterized by tissue destruction spreading along facial planes, may present with sepsis and rapidly progressive rash, and is associated with high mortality. Clinical examination shows rapidly progressive redness, purpura, starting at the entry point of infection. Patient develop tissue necrosis, bulla formation, and palpable crepitus, resulting from bacterial gas production. Necrotizing fasciitis is life-threatening and must be treated aggressively with systemic antibiotic therapies and operative debridement of the affected area. Next. Oh, you know what? It's already your time to sleep.
Okay. Let's do last question. 30.
Okay. Okay.
Okay. 1 week after undergoing splenectomy for injuries sustained a motorcycle collision, a 19-year-old man has platelet count 1 lakh 25,000. Examination shows normal healing wounds. Which of the following is the most appropriate measure to prevent thrombotic events in this patient?
Mm.
Ready?
Mm-hmm. So it is aspirin therapy. You know, see that coming. This patient with significant thrombocytosis following a splenectomy likely has reactive thrombocytosis. Reactive thrombocytosis is the most common cause of thrombocytosis, and common etiologies include trauma, infection, surgery, and malignancy. The spleen is the primary site of platelet destruction and plays a major role in platelet regulation. Post-splenectomy thrombocytosis is common, and platelet counts typically peak 1 to 3 weeks after surgery before returning to normal, and in the following weeks of month. If severe thrombocytosis may lead to thrombotic events such as MI, pulmonary, PE, mesenteric ischemia due to platelet aggregation. Patients with severe thrombocytosis should be started on antiplatelet agents such as aspirin to prevent this complication. It's not heparin or warfarin will be appropriate if the patient develops DVT or P. While these are complications that may occur because of the thrombocytosis, this patient does not exhibit signs of either. Further, warfarin and heparin are best employed to manage hypercoagulability from factor thrombosis as opposed to platelet-driven thrombosis, which is best managed by antiplatelet agents such as aspirin and clopidogrel. Periodic platelet pheresis has been used in patients with essential thrombocytosis who are having life-threatening thrombotic events such as stroke, Limb ischemia. Platelet is only a temporary solution to lower the platelet count and must be followed by definitive management. This patient has reactive thrombocytosis, not essential thrombocytosis, is not currently experiencing any life-threatening complication. His platelet count may be normalized in the coming weeks, and he should be initiated on aspirin and have counts trended. Okay, I'm done.
Okay.
Okay, see you tomorrow.
Okay.